Your adrenal glands are these tiny little things, but they are absolute powerhouses. They manage your body's response to pretty much every kind of stress you can imagine. So, what happens when these crucial glands just stop working? Today, we're diving deep into adrenal insufficiency, a condition where the body's emergency brake fails. And the consequences? Well, they can be life-threatening.
So here's our game plan. First, we'll get to know the body's normal stress axis. Then, we'll look at what happens when it breaks down. After that, we'll play detective and follow the diagnostic pathway, see how we can restore that crucial hormonal balance, and wrap up with some special clinical situations. All right, first up, to really get what goes wrong, we've got to understand how this whole intricate system is supposed to work in the first place.
Okay, so at its very core, adrenal insufficiency is a state of deficit. It's that simple. The adrenal glands, which, by the way, sit right on top of your kidneys, they just can't make enough of the hormones we need to function. And the big one here, the real star of the show, is the master stress hormone, cortisol.
This slide lays out the body's hormonal chain of command, what we call the HPA axis. The easiest way to think about it is like a company. The hypothalamus, that's the CEO, and it sends out an order called CRH. That order goes to the pituitary gland, our manager, who receives it and sends out its own directive, ACTH. This instruction travels down to the factory, which is the adrenal gland, and the factory produces the final product, cortisol. Now here's the brilliant part. Cortisol reports back to the CEO and the manager, letting them know the job is done. This tells them to stop sending more orders. It's a beautiful process called negative feedback, and it keeps everything in perfect balance.
Now, this adrenal factory, it's not a one-trick pony. Its main product, of course, is cortisol, our built-in alarm system for stress, metabolism, and inflammation. But it also produces aldosterone, which is absolutely vital for balancing salt and water to keep our blood pressure in check. And finally, it makes adrenal androgens like DHEA, which play a role in things like libido.
Okay, so we've seen how the system should work. Now let's explore what happens when this elegant process fails. Because a breakdown can happen at any level of that chain of command.
And that really begs the question, right? Where exactly does the failure happen? Is it a problem with the CEO, the manager, or is the factory itself on the fritz?
This table breaks down the three main types beautifully. Let's walk through it. In primary adrenal insufficiency, also known as Addison's disease, the factory, the adrenal gland itself, is broken. It can't make cortisol. So what happens? The manager, the pituitary, keeps shouting orders by releasing tons and tons of ACTH, but nothing happens on the factory floor. Now in secondary AI, the manager is the problem. The pituitary just isn't sending out ACTH, so the factory has no orders and makes no cortisol. And finally, with tertiary AI, the issue starts right at the top, with the CEO, the hypothalamus. Oh, and here's the super important detail. Notice how aldosterone is only low in primary AI? That's because its production isn't entirely dependent on that pituitary manager.
So what would cause the factory itself to fail? Well, in high-income countries, the #1 cause, by far, is autoimmune. The body's own immune system gets confused and attacks and destroys the adrenal glands. Other causes can include serious infections like TB or HIV, cancers spreading to the glands, or some specific genetic conditions.
And what about a problem with the manager, the pituitary? The most common culprit here is a pituitary tumor that messes up ACTH production. Other causes are often iatrogenic, which means they're an unintentional result of medical treatment like surgery or radiation in that area. Less common causes could be something like a pituitary infarction, where the gland loses its blood supply, or even severe head trauma.
And finally, what could disrupt the CEO? The single most common cause of adrenal insufficiency, overall, is the long-term use of external steroids, like prednisone. When you take these drugs, they flood the system. And the CEO, the hypothalamus, sees all this extra cortisol and just shuts down. It stops sending orders. And over time, the entire axis just goes dormant. So, with all these different potential causes, how on earth do clinicians figure out what's going on? Well, it's kind of like a detective story. You have to follow a trail of clinical and biochemical clues to solve the mystery.
The initial clues can be frustratingly vague. Patients feel totally exhausted, they lose their appetite and weight, they get dizzy when they stand up, they have muscle pain. It could look like a dozen other things. But there is one really specific clue, a craving for salt. That points directly towards primary AI, because that's when aldosterone production is also lost.
But check this out. There is one very dramatic telltale sign that is unique to primary AI, hyperpigmentation. Remember how in primary AI, the pituitary manager is just screaming out ACTH? Well, it turns out the precursor molecule for ACTH also produces something that stimulates our pigment cells. So all that extra ACTH leads to more melanin, causing this distinct darkening of the skin. You see it especially in sun-exposed areas, skin creases, and even inside the mouth on the gums.
From there, the investigation moves to the lab. The first step is a blood test, usually right around 8 a.m., because that's when cortisol should be at its peak. If the cortisol is really low, say under 5, the diagnosis is pretty likely. So then we look at the ACTH level to figure out who's at fault. If ACTH is super high, it's the adrenal's fault, primary. If ACTH is low, the problem's higher up the chain, secondary or tertiary. Now, if the result is in that gray zone, we do what's called a stimulation test. We basically inject some synthetic ACTH and see if the adrenal gland can wake up and respond. If it fails to produce a good amount of cortisol, that confirms the diagnosis.
Once AI is confirmed, the last piece of the puzzle is to find the root cause. For suspected primary AI, we can do a blood test for specific autoantibodies that will confirm if it's an autoimmune issue. For secondary or tertiary AI, getting an MRI of the pituitary is essential to look for any tumors or other structural problems.
So, once the diagnosis is crystal clear, we can move on to treatment. And the goal here is actually quite simple. Replace what's missing and give the body back the hormones it so desperately needs to function.
The absolute cornerstone of treatment is glucocorticoid replacement. The preferred first choice is usually hydrocortisone. It's short-acting, so it's given in 2 or 3 daily doses, which does a better job of mimicking the body's natural cortisol rhythm. For patients who might have a tough time with multiple daily doses, there's a longer-acting option like prednisone that can be given just once a day.
But we can't forget about the other hormones. Patients with primary AI also have to replace the missing aldosterone. We use a medication called fludrocortisone to help them manage their salt and blood pressure. And for some women dealing with low energy or libido, a trial of DHEA replacement might also be considered.
Now, I want you to listen closely, because this one piece of patient education is not just important, it is absolutely 100% life-saving. A person with adrenal insufficiency can't make extra cortisol when their body is under stress from an illness, an injury, or surgery. They must be taught to manually increase their steroid dose. We call this stress dosing. Forgetting to do this can trigger a life-threatening adrenal crisis. This education is paramount. It's everything.
Finally, let's talk about how management isn't a one-size-fits-all deal. Certain situations require special attention and some careful adjustments.
Pregnancy is the perfect example. The body's demands just go way up, so the hydrocortisone dose typically needs to be increased by the 3rd trimester. And during the incredible stress of labor and delivery, a high-stress dose of IV hydrocortisone is given to protect both the mother and the baby.
And all of this brings us to the ultimate challenge in managing this condition. Look, our current therapies are good, but they're not perfect. They're not a perfect copy of the body's natural, delicate rhythm. Which leaves us with a final question to think about. How can we innovate to create therapies that more perfectly mimic nature's rhythm? How can we free patients from the constant burden of managing their condition, and in doing so, truly transform their lives?